Hi everyone. Hello. How are you all? How is your preparation going? Did you revise the endocrinology part? Yes, you guys have to be active. Okay. Otherwise, you know, I'm sharing the PPT of today's discussion on the group. Just a second. I've shared the PPT in the group. So thing is, please don't print that PPT as of now. I am gonna edit it few slides from that. So once after the end of the session, we have the complete PPT, then only you print it. Okay. So why it's not showing? Just a second. Yeah. Yes, Sagar is there. All of you, please let me know that if everything is okay in your preparation. Yogendra is there. Sheikh Rubina. Talavani is there. Then Rahima, Rishikesh, everybody. Manoj, hello. Gauri, hello. Vishwa is there. Did you revise the endocrinology, all of you? Shall I ask few questions based on the endocrinology now? This will be easy one. So we'll just have a quick summary from the pituitary itself to the adrenals. I'll just ask one question on each of the topic just to check that how your awareness about the situation is. Okay. So we have, yeah, 35-year male. Okay. Now he is having reduced growth hormone. His overall growth is reduced. Okay. We did his pituitary function test. Okay. So in pituitary function test, we checked for his growth hormone, FSH, LH. Okay. Everything was low. All right. Now, he doesn't have well-developed secondary sexual characters. So for that, what medications you would give? Okay. For secondary sexual characters. Okay. His gonads are well developed. Gonads are okay. But secondary sexual characters are not well developed. Okay. So option one, recombinant LH. Option number two, DHT. Option number two, option number three, FSH. Option number four, FSH and LH. We found hypopituitarism in it. Plus, since 1 week, he also complains of color vision defects. Color vision defects. Now, this is not difficult question, but just try to answer this one. So why so many people left? Okay, joined as guest and then left. Okay, let it be. You guys are not able to answer this one, or like The internet and all my audio, everything is okay, right? You are able to listen to me, right? Is it better now? I hope it is little better, the audio. Yeah, DHT is the answer. Correct. Okay. So always remember we need DHT testosterone for the secondary sexual character or viralization. And for gonadal development, we need the pituitary hormones. Okay. So that's one basic question. Now, if patient comes to you with buffalo hump, okay, weight gain is there, pigmentation is there on skin. Okay, that can be in the form of acanthosis nigricans. Okay, not the other kind of pigmentation. This is acanthosis nigricans. Okay, even hypertension was noted. Okay, now when we did 6 mg DEXA suppression test in this patient, cortisol level dropped. So where is the cause? What is the diagnosis of this patient? Tell me in one word. Diagnosis is, yes, guys. I will give you options. Option number A, Cushing's disease. Option number B, Cushing's syndrome. Option number 3, Cushing's like done already. Addison's. And option number 4, ectopic Cushing's. Okay. Yeah, but I have been specific over here, right? I have also given the answer option of Cushing's disease. And ectopic Cushing is also there. Okay, so this is not making any sense. So is this Cushing's disease or Cushing syndrome according to you guys? Yes, Arshi, you can answer, right? The answer is Cushing's disease. Because as you can see, this is because of the pituitary adenoma. Please remove this annotation, whoever has done these annotations. Okay. Please don't do annotations and all. Just answer in the chat box. Okay. The answer is Cushing's disease. No. Because as you can see, after giving DEXA, the suppression of the cortisol has occurred. That means pituitary suppression is there. Okay. If there is no suppression of the cortisol, that means ectopic ACTH is there. Okay. Okay. That means ectopic ACTH is there if there is no suppression. But here there is a suppression. So the cause would be Cushing's disease. Okay. I hope you got it. Coming to the one more test. Now tell me about the main syndrome. Main one. What is the gene affected with the main one? What is the gene that is affected with the main syndrome? Yes. Come on. Menin. And what about main 2A and main 2B? Very good. And what are the things that are seen in the main 1A? Main 1, basically. Okay. PAR, PANPIT. Okay. Parathyroid adenoma, pancreatic, and pituitary. So pancreatic can be in the form of exactly. Okay. PAR, PANPIT. Okay. Parathyroid is the commonest. All right. So this parathyroid is the commonest, and pancreatic adenoma can be in the form of pancreatic can be in the form of all like insulinoma, gastronoma, etc. Everything can be there. Now, when we talk about the main 2A, what are the main 2A things? Yes. Parathyroid will be repeated. Okay. Then medullary thyroid carcinoma is there. Very good. And pheochromocytoma. Very good. And what about meant to be? Parathyroid will be not there, but there will be pheochromocytoma. There will be mucosal neuromas, and there will be medullary thyroid carcinoma. Okay. So that's all about the importance in the men 1, men 2, men to be. Now, what about autoimmune polyendocrine syndrome, APS1? What was the gene that is affected in the APS? Yes, you guys know this. Nice, very good. AIR gene. Okay, AIR gene. And what about the APS2? What about the APS2? APS1, APS2. What about the APS1? APS1 was AIRE. APS2 was the polygenic. Okay. Here, there was association of the mucocutaneous candidiasis as well. Okay. Here was not such skin association. And when we talk about the diseases per se, in case of APS2, we had Addison's disease. We had autoimmune thyroid. Okay, can be both hypo plus hyper and type 1 diabetes. Okay, and when we talk about the APS1, we had Addison's again. Okay, then we had hypoparathyroidism. Okay, so that is importance about the APS1 and APS2. I hope you understood this. Apart from that, in endocrine, obviously acromegaly, all Cushing's syndrome, Cushing's disease, Addison's disease, Conn's syndrome, pheochromocytoma, everything is very important. Okay, so make sure you revise those topics. Now let's start with the today's discussion. I'll just erase this part because we will need some space to revise. Okay. All right. So when we talk about the neurology now, we'll go step by step today also. First, we will discuss about in short, we will discuss about the syncope. One second, I'll just, yeah. So first we will discuss about the syncope, then seizures. Okay. Then we'll discuss about the stroke. Then neurodegenerative disorders. Okay. So this is our target for today. Okay, we will discuss most of the important stuff, what has been asked and what we can be asked in the individual topics. Okay, right. So let's start. Right. So we know when we talk about the syncope, we have three types of syncope. Okay. First is your neurally mediated syncope, which can be in the form of vasovagal syncope. Then you can have cardiac syncope. And third, you can have the orthostatic hypotension. Okay. Yes. And out of which the main cause of the syncope in the young individuals will be commonest will be neurally mediated syncope. Okay. If there is no underlying cardiac conditions, obviously. Okay. So what is syncope itself is transient, self-limited loss of the consciousness. We know the definition, but remember here, there is a self-limiting loss of the consciousness. Okay. And that's how basically you can distinguish between the seizure versus syncope. Okay. Due to acute global impairment of the cerebral blood flow. And it accounts for 3% of the emergency visits. Lifetime incidence is 35%. Most common can be seen in young adults. And one of the commonest is neurally mediated, followed by cardiac, followed by orthostatic hypertension. Okay, so this can be just what you can remember. Okay, so neurally mediated can be in the form of vasovagal syncope. Whenever your vagus gets activated, you can have syncope because of the peripheral pooling of the blood. Right? So we have neurally mediated, orthostatic hypertension, cardiac syncope. So obviously, cardiac means arrhythmia, either bradyarrhythmia or severe tachyarrhythmia. For example, if you have atrial fibrillation, because of the fibrillatory movement, there will be not enough blood will be passing to the circulation. So you can have the syncope. Okay. So neurally mediated, as I said, vasodilation, bradycardia, and reduced cardiac output. Okay. But remember here, the triggers are very important. So pain, emotion, orthostatic stress is there, and symptoms can be in the form of pallor, yawning, nausea, myoclonus, etc. When we talk about the orthostatic hypertension, so orthostatic hypertension again can be caused by the autonomic failure, right? Because whenever we stand, our baroreceptors get activated, right? And whenever our baroreceptors are activated, obviously our body tries to increase the peripheral vascular resistance so that the peripheral pooling of the blood does not occur. Blood goes into the heart, goes into the brain, and that's how you reduce the formation of the syncope in the normal person. But what happens in the some people who are aged, or some people who are having diabetic, or some people patients who are having autonomic failure, there is disturbance or there is a problem in this stretch receptor or baroreceptors, and because of that, your peripheral pooling of the blood occurs and orthostatic hypertension occurs. Okay, so sympathetic failure, that is a mechanism behind that, and volume depletion can also be one mechanism. Okay, so triggers obviously sudden standing. If you eat something, obviously there is again splanchnic vasodilation. Blood will go more into the gut. That can also cause syncope. And after certain medications, also you can have orthostatic hypertension. So, what are those medications which can cause orthostatic hypertension? Yes, you guys, be smart. Be attentive in the class. Drugs which can cause orthostatic hypertension. Very easy. Beta blockers, calcium channel blockers, beta blockers. All the antihypertensive drugs will be right. Logically, है ना? Right? So this can cause a diuretics, etc. can cause orthostatic hypertension. And what is the drug that is used for the basically for prevention of or treatment of the orthostatic hypertension? You guys know pharmacology, right? What are the drugs we use for orthostatic hypertension? Have you heard about this? We read about this in our additions, no? And we can also give midodrine. Okay. So these are the drug, fludrocortisone. Okay. Then fludrocortisone, then midodrine. Okay. Epinephrine. Okay. Epinephrine, like it will be whenever you are in the ICU, etc. Okay. So, right. I hope you understood. So the three important causes: neurally mediated syncope, orthostatic hypertension, and cardiac syncope. Cardiac means arrhythmia, etc. Okay. So cardiac will obviously have sudden collapse, exercise, palpitation associated, and similarly symptoms will also be like that. So coming to the pathophysiology of syncope, primary cause of the syncope will obviously global cerebral hypoperfusion, which we just discussed in the definition, right? Then what is the commonest prodromal symptom of the syncope? So obviously lightheadedness, okay? So neurally mediated syncope will have lightheadedness, dizziness, fatigue. Cardiac syncope will have sudden blackout, complete blackout, and orthostatic hypertension will have dizziness, lightheadedness, same, okay? Coming to the diagnostic evaluation. So for diagnosis and evaluation, we do echo to check if there is any cardiac cause or anything like that. Okay, the individual, we based on the cause, we have different tests. Okay, so history, obviously, we have to ask if there is a history of triggers. Then check for the postural changes to rule out orthostatic hypertension. ECG, echo, tilt table test for checking of autonomic failure. Okay, and finally ECG to check out if there is any other pattern. Right. Finally, treatment. So obviously, if it's neurally mediated, give patient education that whenever he's standing, you should take some time, or you can give fludrocortisone, vasoconstricting agents. Okay. Then orthostatic hypertension, again fludrocortisone, midodrine. Okay, L-dihydroxyphenylserine, phenylserine. Okay. Then cardiac syncope. Again, in cardiac syncope, you can give antiarrhythmic agents, pacemaker, antiarrhythmic, and defibrillators. That's all about the syncope. Now, whenever you have syncope, whenever patient comes to you with unclear history of either it is seizure or syncope, we tend to get confused. And for the same, we should ask the proper history. That was it really seizure or syncope? So, what are the points that differentiate between seizure versus syncope? Okay, so there are certain points. First of all, immediate precipitating factors for syncope is always there. That means triggers are always there. Okay. So triggers are always there for syncope. Then premonitory symptoms can be there in case of syncope, tiredness, nausea, etc., etc. Here also aura can be there. Then posture at onset can be usually erect. Mostly when you stand suddenly, there will be syncope. Okay. Then duration of the unconsciousness is usually seconds over here. Duration of tonic-clonic moments here never more than 15 seconds, and here it can be 30 to 60 seconds. Very important. So obviously it's seizure, so there will be tonic-clonic moments. Okay. Then facial appearance during event. So here cyanosis, frothing of the mouth, tongue bite can occur. So that's very important differentiating feature between seizure versus syncope. Okay. So here is that point noted. Tongue bite, it's very common over here and it is rarely seen. Now disorientation, many minutes to hours. Okay. And here less than 5 minutes it is there. Now aching of the muscles often, and here it is sometimes. And headache sometimes, and incontinence can also occur in both of them. So always remember, now whenever you have the MCQ that is asking the difference between seizure versus syncope, you know now whenever they give incontinence. So in both you can see incontinence. Okay. So just a second, guys. There is someone at the door. Just a second. Yeah. So now when we get MCQ, make sure you are aware that incontinence is a part of the both, but the loss of consciousness more than 15 seconds is never seen in the syncope. Okay. Now let's start with the epilepsy. There are some MCQs and the topic I have tried to cover in detail. So introduction to the seizures, right? So can anybody tell me what is the population will have at least one seizure in their lifetime? Can anybody? Yes, guys. Not one to do, but even more than that. Okay. So see, 5 to 10% of the population experiences at least one seizure in their lifetime. Okay. And prevalence, generalized epilepsy. So this is seizure. Okay. This is seizure prevalence. And this is the incidence of the epilepsy. So incidence of the epilepsy is 0 to 3, 0.3 to 0.5%. Okay. In population. Now, causes of epilepsy can be variable. So, depending on the condition, either brain injury, infection, stroke. So, depending on the age group, we have different types of the epilepsy, right? So, can you tell me which of the following is no longer used in the classification of the seizures? You guys know now what we use right now? Do we use partial and complex, or we use focal or generalized? Okay, so we use, yeah, no, no longer. So we don't use partial now. Okay. Generalized we use, focal we use, absence we use. Okay. So absence is a type of generalized seizure. Okay. So absence is a type of generalized seizure. Okay. So the answer would be your partial seizures. Okay. So that is not used now. Earlier this terminology was used. Right. Now coming to the next topic. Now obviously we're talking about the seizure only. What is the most common form of the seizure seen when focal seizure evolved to generalized seizure? So you know, focal seizure, that means it is developing in the one particular part of the brain. So suppose this is your brain. Okay, right? So this is how, okay, this is how suppose it is the brain. And focal means it is developing at one part over there. and if it is traveling to the all the other parts. Okay. So this is your focal. And when it passes to all the parts, that is your generalized. Okay. So focal will obviously start from the one point, as the name also suggests. But when we goes to the generalized conversion, what is the most common type? Absence, tonic-clonic, myoclonic, or atonic? Very good. Tonic-clonic is the correct answer. Yes, tonic-clonic is the correct answer. And overall, it is the commonest type of the generalized epilepsy. Okay. So that's why tonic-clonic is the answer. Then what is absence seizure? So absence seizure means there is a, we'll discuss in detail coming forward, no problem. Okay. So we have focal onset seizure, we have generalized onset seizures, and we have unknown onset seizures. Okay, so we don't exactly know that from when the seizures are there. Okay, so in focal onset, we have motor, tonic, myoclonic movements can be there. Okay, so it originates from the specific brain region. Generalized involve both hemispheres. So why I've added this point is because this question can be asked as a all of the above are true about epilepsy. They will give you option one, that focal epilepsy starts from the one specific brain origin. Generalized epilepsy starts from the both hemisphere. Generalized epilepsy starts from whole single hemisphere. And the fourth option will be absence seizure is the part of the generalized epilepsy or generalized seizures. So what will be the answer? C, not single hemisphere, but both hemispheres. I hope you got it. So types are obviously motor, in which tonic-clonic, myoclonic, or tonic is there, and non-motor, in which absence is there. Okay, so here also in non-motor, we have sensory and autonomic symptoms. Now, let's go into the next question. Which of the following tool is often used to identify the origin of the focal seizure when the interictal EEG is normal? So this is thoda NEET SS type question. Okay, this is NEET SS level question, but try to attempt this one. Let's see if you can attempt. So that they are saying that during focal seizure between the interictal episode, EEG is normal. Now, how do we identify that? So in such cases, we do surgery, neurosurgery is done, and there are permanent electrode, or not permanent, but temporarily we can place the electrodes in the brain to catch the activity. And that is called as intracranial electrodes. Okay, so we do intracranial electrodes and we check that from where the focal epilepsy is coming. Okay, next question. Now there is one phenomenon when we talk about the focal epilepsy or focal seizures, when it gets transferred into the rest of the body with generalized epilepsy. So that phenomenon is called as Jacksonian march. Now the question is, progression of the sensory symptoms are there or progression of the motor symptoms are there? So can you answer this one? A progression of sensory symptoms is there or spread of motor activity from localized region? Or rapid spread of selector from focal to generalized? Or parallels of the region after the focal? What do you think? Yes, almost everyone, all of you are correct. So there is a spread of the motor activity. Okay, obviously GTCS. Okay. Now, this is the summary, what we just discussed. Okay. So when we talk about the focal seizures, we have two things. Focal seizures with intact awareness, focal seizure without awareness. So focal seizures are usually with the intact awareness. That means when the seizures are coming, you are kind of know that I am getting seizures. Okay. And what is impaired awareness? Here, to avoid or to just buffer that period of time, you will do certain activities. For example, lip chewing, okay, or you will do lip smacking, lip chewing, etc. All these things can be done, and it is usually associated with the aura. Okay, so focal seizures with intact awareness. Here, motor in the form of tonic, clonic, myoclonic can be there. Paresthesia, vertigo can be there. And here, in case of impaired awareness, you will have aura, either sensory, emotional, and motionless stare at onset can also be seen. And there is a automatism. So this is very, very important point. Please note this, that automatism is a feature of the focal seizures, focal epilepsy, and that too focal seizures with the impaired awareness. Very important point. Okay. Along with that, there can be postictal confusion or amnesia also seen in these questions. Okay. Commonest symptoms of this intact awareness will be Jacksonian march, Torts paralysis, epilepsia partia continua. So what is this epilepsia partia continua? That means refractory seizures will keep on continuing in certain cases. starts with the focal epilepsy, and that focal epilepsy actually doesn't even get better, even if you're giving any medication for that. Okay, so I hope you understood that. So torch paralysis, torch paralysis, we will see one more MCQ on that. Don't worry. Okay, so it is basically temporary paralysis after the focal seizures. Now, seizure evaluation will be focal to generalize. Here also focal to generalize, and EEG findings can be moreover same in this. Okay, now coming to the generalize. So, which of the following is the main seizure type in 15 to 20% of the children with epilepsy? Main seizure type. So, we've just discussed generalized tonic-clonic seizures is the, sorry, you guys can answer this. That is, see, they have given the percentage, huh? They have given certain percentage. So, according to that percentage, you have to answer. Okay. Then which of the following EEG findings are typically seen in absent seizure? These are typical absent seizure. Huh? Make sure you know. Yes. Exactly. Easy answer. 3 hertz spike slow wave pattern will be there. For example, this spike will be there, and then slow wave, slow spike. Okay, this kind of pattern is there. Then which seizure type is the most commonly associated with the drop attacks? So this is also easy question. You guys know this. This third question. Yes, you guys, please. Correct. Very nice. The B is the answer. Okay. Drop attacks, atonic seizures. So here we have the different types of the generalized epilepsy. Okay. So we have typical absence seizures. So typical means obviously there will be sudden brief loss of consciousness will be there. And there will be subtle motor signs can also be seen in these patients. And EEG will also have subtle features are important, that classic features, that is 3 hertz spike and down, a spike and slow wave discharges. Okay. That is typical for the typical seizures. So duration will be seconds, and it can be seen in childhood, often misdiagnosed as ADHD. That is attention deficit disorder. Now, atypical absence seizures. So again, atypical can have longer lapse of consciousness, whereas this absence was sudden and brief loss. Typical was brief loss. And in atypical, I'll just zoom it so that you don't get distracted. Okay, so we are discussing typical versus atypical. In typical, there will be brief loss. In atypical, there will be longer lapse of consciousness. And here, this is important. This is very important point, that in case of atypical absence seizures, there will be slow spike and slow wave pattern. Whereas here was 3 hertz spike and wave pattern. Okay, here is a slow spike and slow wave pattern. That is less than 2.5 hertz. Now here, the duration can be longer than the typical absence, and it can be associated with the brain abnormalities as well. So that is the difference between typical absence and the atypical absence. Now, can you tell me where was the automatism? When we discuss automatism, was it with the focal seizures with intact awareness, or focal seizures with impaired awareness? A or B? Yeah, correct. Okay, with impaired awareness. And absence seizures and focal seizures are different. Just make sure you remember. That's why I asked these questions. Now coming to the GTCS, obviously in GTCS, in tonic phase, there will be increased tone of the muscle. That will cause muscle contraction. And in clonic phase, there will be alternating relaxation and contraction. Okay, and it is typically associated with the post-ictal confusion as well. Your ECG will have the polyspike discharge. This is very important. You will have fast and polyspike discharge. We will discuss the EEG also. I have added the EEG images from the Harrison itself. So we'll discuss that. Okay, that is your generalized tonic-clonic seizures. Coming to the atonic seizures. So atonic seizures are typically associated with the loss of tone. So sudden loss of muscle tone, drop attacks, and risk of injury is very common in these conditions. Okay, so duration can be 1 to 2 seconds, and generalized spike and wave pattern can be seen in these patients. Okay. Now coming to the myoclonic epilepsy or myoclonic seizures, here there will be brief muscle contraction and may involve entire body of the person. Okay, so that is your myoclonus. bilateral synchronous spike and wave pattern can be there. And typically, if it is seen in the children's, that is juvenile myoclonic epilepsy. And finally, coming to the epileptic spasms. So this epileptic spasm will have this type of hypsarrhythmia. That means burst and suppression type of pattern. Okay. Again, can be seen in the infantile spasm syndrome. Okay. So that is your epileptic spasm. Here, sustained flexion and extension of the proximal muscles. Okay. This is usually infantile in the onset. So these are the generalized epilepsy types. Okay. Right. Now coming to the epilepsy syndromes. Very important. Which of the following is the key characteristic of the juvenile myoclonic epilepsy? So we just discussed that. You guys please answer this one. Answer this one. What is the answer for the first one? Correct. Very good. So the easy one. See, juvenile myoclonic epilepsy mostly have the myoclonic seizures, and it is usually seen early morning when you wake up, and usually associated with the sleep deprivation. Okay, so it is bilateral myoclonic jerks often provoked with the sleep deprivation. So seen in the early morning, right? Then we have Lennox-Gastaut syndrome, most commonly associated with which of the following? Single type of seizure, tonic-clonic only, not okay. It has multiple type of seizure. Tonic-clonic can be there, absence seizures can be there, drop attacks also can be there. Okay. Then slow, less than 3 hertz spike and wave pattern is associated with the Lennox-Gastaut syndrome. No. Okay, can be. Okay, can be. Then absence seizures with complete remission, not necessarily, and non-epileptic causes of the brain dysfunction. So what is your answer? Yes, Lennox-Gastaut will have the less than 3 hertz spike and wave pattern. That is differentiating from the absence seizures. Which of the following is the third in the epilepsy syndromes? We have mesial temporal epilepsy, in which there will be your temporal sclerosis. So what is the cause for that? So what is the answer for this one? So that hippocampal sclerosis observed in the MRI is the answer. Okay. Yes. Very good. Very good, Vishwa. Very nice. So let's see the summary of the epilepsy syndromes. So juvenile myoclonic epilepsy, Lennox-Gastaut syndrome, and the mesial temporal epilepsy. So in juvenile myoclonic epilepsy, there is a bilateral myoclonic jerks, often in the morning. And this myoclonic generalized tonic-clonic absence can be there. Different types can be there. Okay. Myoclonic, generalized, tonic-clonic, and absence. All the other types can be there. You will have normal or generalized spike wave pattern. Okay. And genetic polygenetic association is usually there in this patient. Family history is common, and good response to the anticonvulsants. Okay. That is very important. Coming to the Lennox-Gastaut syndrome over here. So here we have the triad of multiple seizure, cognitive impairment, and the generalized and the slow less than 3 hertz spike and wave discharges. So that is the triad for this Lennox-Gastaut syndrome. Okay. There will be generalized tonic, clonic, atonic, and absence. These are the various types of the Lennox-Gastaut syndrome, and causation can be multifactorial. Okay. So you have to treat according to the causes, but remember it has poor prognosis and difficult to control seizures. Okay. Very important point over here to be noted. Coming to the mesial temporal epilepsy, again, this is also very difficult to treat. And as there is a hippocampal sclerosis, we mostly have to do surgery in this patient. Unless we do hippocampectomy, there is no relief for these patients mostly. Okay. So surgery is the hippocampectomy. Okay. So patient may have focal seizures, impairment of the consciousness also can be there. Okay. So these are the 3 common syndromes that you should know. Juvenile myoclonic epilepsy, which is usually common and often in the morning. Lennox-Gastaut syndrome, usually associated with the multiple seizure, cognitive impairment can be there, and the slow less than 3 hertz slow wave and pattern can be there. And mesial temporal epilepsy, where hippocampectomy is the only option. So these are the various types of the epilepsy now, right? So we will start from here. So this is of the normal. Okay, A is normal one. Okay, B is your abnormal, and it is, as you can see, multiple constant activity is there now. That is because of the encephalopathy. Okay, continuous seizures are there, encephalopathy, or continuous hyperactive brain is there. That is your encephalopathy. Okay, encephalopathy. Now coming to the type 3. that is your C over here. Here also you can see irregular burst pattern is there. Okay, irregular burst pattern is there. Okay, can be seen in the diffuse pattern, can be seen in the juvenile myoclonic epilepsy. Okay, now coming to the D over here. So C is irregular slow activity, can be seen in the right parietal glioma, and D is the periodic complexes occurring once every second. Okay, you can see once every second it is occurring this kind of periodic complexes, and these periodic complexes are very classical for the Creutzfeldt-Jakob disease. You know, that is the prion disease. Okay, that is one of the prion diseases. So Creutzfeldt-Jakob disease, in which patients presents with the progressive dementia, and you can get typical this pattern in these patients. Okay, so periodic complexes of the burst can be there. Now here are some other patterns. So here this is the diffuse pattern of the myoclonic epilepsy. Okay, then this is your burst pattern. Okay, and this is your 3 Hz spike and slow wave pattern. Okay, so C is your 3 Hz spike and slow wave pattern. See, 3 Hz spike, slow wave, 3 Hz spike, slow wave. Okay, 3 Hz spike, slow wave, 3 Hz spike, slow wave. So this is your absence scissors. Okay, so I hope you understood the EEG also now. Now coming to the pathophysiology of the seizure, so it's very easy. There are so many, just like what we see in the action potential of the cardiac muscle. Here also there is a increase in the neuronal activity that leads to the triggering of the epilepsy, right? You guys know this. So seizure results from which of the following? So imbalance from the neuronal excitation and the inhibition. We know there are certain excitatory neurotransmitters and inhibitory neurotransmitters. Excitatory in the form of glutamate and the inhibitory in the form of GABA. All right. So if there is any miscommunication between two, you can get the epilepsy. So excitation with the glutamate, inhibition with the GABA, and spread mechanism can be focal or generalized. And epileptogenesis is basically that how much epileptic or epileptogenic tissue is there. Okay, so that is the mechanism behind that. Now talking about the clinical features, we have already discussed that. Just have a small, let's have a small review over here. You guys answer this one. Focal seizures with impaired awareness. We already discussed this automatism. Okay, so here you can see focal seizures, intact awareness. We will have abnormal movement, paresthesia, flashing lights can be there. Focal seizures with impaired awareness, you can have chewing, lip smacking, repetitive movements, confusion, post seizure can be seen. Very important. That is your focal seizure with impaired awareness. Coming to the generalized, obviously tonic-clonic can be there and absence can be there. Auras can be there for focal seizures, which can be in the form of deja vu, abnormal smells, sudden fear, rising sensation in the stomach. Okay, all these things can be there. And post-ictal phase confusion can be there in the focal as well as in the generalized. Coming to the diagnosis, obviously we do the EEG. We have just saw the EEG part as well. We can do MRI to just check if there is any hippocampal sclerosis, if there are any cortical malformation, tumor, vascular region, stroke. Okay, just to rule out all of these things. Now coming to the management of the epilepsy. Very, very important topic. You will 100% get at least 2 MCQ on the epilepsy. Very important. So which of the following is the first line treatment for the focal seizures? Yes, you guys know this, and this is so easy. Yes. Easy one, right? So when we talk about the epilepsy, there are different things. Okay. For focal epilepsy, we have different medication. For generalized, we have different medication. You can't use cross match. Okay. So there was one question. Let's see who answered that. Okay. Patient. Okay. So we had a patient. This is the patient, young patient. Okay. And his right hand was actually having epilepsy. Okay. So this is a focal epilepsy. So what question they asked, that which of the following medication cannot be used in this patient? Carbamazepine. They asked about phenytoin. Okay. They ask about levetiracetam. Okay. And they ask about valproate. So now whatever we have studied till now is like all medication can be used in all conditions. But obviously CBZ, carbamazepine is more specific in the focal epilepsy. But there is one exception, that is valproate. Okay. Yes, valproate is typically only indicated for the generalized epilepsy. Okay. So carbamazepine, oxcarbamazepine, lamotrigine are the first line for the focal epilepsy or focal seizures. And generalized, you have valproate. Okay. And see, in additional or second line, you don't have valproate here also. You have levetiracetam, phenytoin, and the topiramate. Got it? And similarly, in generalized epilepsy, we don't prefer carbamazepine. Okay. So levetiracetam, lamotrigine is there, topiramate, zonazepam, and phenytoin can be there. Coming to the absence seizure, again, ethosuximide, valproate is still here, can also be used, and lamotrigine can also be used. Okay, so it is alternative for the children's. Coming to the myoclonic seizures now, valproate again plays very important role, and levetiracetam also plays important role over here, and topiramate, clonazepam can also be used. Lifestyle modification will be adequate sleep, avoiding seizure triggers like alcohol or sleep deprivation, and even stress reduction technique by exercise and meditation. It's very important. Okay, so this is important point. And there is one point about the levetiracetam that you guys might not know. It's important to know. Okay, that levetiracetam is not recommended for the atonic seizures. Okay, because there is not enough evidence available for that. So in atonic epilepsy, you don't give levetiracetam, you give other agents like valproate. Okay, so this is very important, right? Coming to the table summary of what we just discussed. In this, there is only one or two important points that you should know. So remember, goal of the anti-epileptic therapy is always to prevent seizures without adverse effect. Okay, that is very important. Then when to initiate therapy, if you have more than one episode or recurrent seizures are there, or there is any organic cause in the brain for the epilepsy. Okay, so there is any uncorrectable cause in the brain or recurrent seizures are there. Even if it is first seizure and there is some problem in the brain, IC bleed, etc., you can start anti-epileptic. Or if you are having recurrent seizures more than 2 episodes, then you can start the anti-epileptic. Drug selection factor, so just what we discussed based on that. And focal seizure, as we discussed, oxcarbamazepine, carbamazepine, lamotrigine, phenytoin, levetiracetam. Okay, side effects and the risk, obviously sedation, ataxia, diplopia can be there. Special consideration can be given for the woman in the childbearing agents because you should avoid valproate and because it has teratogenic property. Okay, even phenytoin. Now, second line, you can use zonisamide, brivaracetam, tigabayne, gabapentin, and lacosamide. Very important. Now, this is the one of the important point, and has been asked also that see SLC2A mutation. Okay, so here also can be associated with the epilepsy, and in case of SCN1A mutation, okay, that is sodium channel mutation, you should avoid phenytoin. Okay, phenytoin and lamotrigine. So this is the most important point in this table that you should avoid. Okay, so this is just a factual information that whenever you have sodium channel 1A defect, you should avoid phenytoin because it can lead to the there will be no effect of the phenytoin and lamotrigine in such cases because they act through those channels. Okay. So now coming to the investigations part. Again, investigation part we have just this. Sorry, this is the your surgical treatment part. Surgical treatment. Okay. So surgical treatment for the epilepsy. So when we do indicate the surgical treatment for the epilepsy, so this is very important. Remember, focal epilepsy, not generalized epilepsy, is the indication. Okay, so focal epilepsy is the indication for the surgery, and failed medical therapy is the indication for the surgery. Okay, so make sure you remember this. If you have focal epilepsy, obviously it will be easy for removing that part, right? And if you have generalized epilepsy, it will be difficult to remove that part. I hope you understood. Okay. What are the common surgeries we can do? Temporal lobectomy we can do. Amygdala hypopempectomy can be done. Okay. Then lesionectomy. If there is particular lesion or if there is any scar, we can remove that. Okay, so we can do either a specific procedure or specialized procedures also can be done, right? So these are the certain things we do. Usually success rate is 70%. Complication can be less than 5%. But here, for you all, indication is only important point. And if you're preparing for any theory exam and for NEET essays, this is also possible. Correct? So that's about the epilepsy. There are certain also more things that are associated with epilepsy. Let's discuss that now. So what is the typical duration? So we will start with the status epilepticus now, obviously. And after that, we have some other issues like. So what is the typical duration of the seizure activity? In generalized convulsive status epilepticus that prompts acute anticonvulsive therapy. Yes, guys? Why are the students, some students are leaving? Yogendra, Nish, why they left? Not 30, not 15, not 2 minutes. The answer is 5 minutes. Very nice. Okay, how can you miss this one? Definition is 5 minutes only. Okay. Now, which of the following is the diagnostic tool crucial for detecting ongoing status epilepticus in a paralyzed and comatose patient? So this is very easy question. I've just added because it is important over here. Yeah, EEG is the correct answer, right? EEG is the logical answer. So status epilepticus is the continuous or repetitive seizure without return to the baseline and consciousness between the episodes. Okay, there is no return to the baseline or consciousness between the episodes, and it is continuous or repetitive seizure activity. Okay, so it has several subtypes. Either it can be generalized convulsive or non-convulsive status epilepticus. So I will just tell you an example. The patient was in the ICU. Okay, and we were actually worried that what is this condition and why is not getting weaned off. So weaned off means why we are not able to remove the ventilator of this patient. So he was having brain hemorrhage, managed for that, operated, surgery was done, etc. Everything was done. We started antiepileptics. Then after a few days, we stopped and tapered, basically. We not completely stopped, tapered. And then suddenly he started having epileptiform activity in the brain. Obviously, he was not waking up. So we did EEG and we found that there is epileptiform activity in his brain. So that's how we got to know that this is non-convulsive status epilepticus. Okay, so status epilepticus can be both convulsive as well as non-convulsive, and essentially the treatment is same for both of them. Okay, so generalized convulsive status epilepticus and non-convulsive status epilepticus. So here, without motor abnormalities will be there. Okay, you will not have the tonic-clonic feature, but just patient will be unconscious. So time frame traditionally defined as seizures 15 to 13 minutes. Okay, this is why I think you guys selected the 30 as an answer. But remember, the therapy should be initiated when the seizures persist beyond 5 minutes. This is very important point. Okay, make sure you not forget this. Now, clinical concerns include status epilepticus, particularly generalized tonic-clonic epilepticus or convulsive status epilepticus, can have cardiorespiratory dysfunction, hyperthermia, metabolic derangements, irreversible CNS injury can also be seen in these patients, and CNS injury can still occur in the neuromuscular blockade. Okay, and electrographic seizures may persist undetected many of the times. So, coming to the common causes of generalized convulsive status epilepticus. Okay, so number one is the anticonvulsant withdrawal or non-compliance. So that was what we did in our patient. Okay, or many patients that come in with the status epilepticus in your hospital. No, this is the non-compliance is very important cause behind that. Second cause is metabolic disturbances. So what are the metabolic disturbances? Like uremia. Okay, uremia can be one cause. Hyponatremia can be one cause. Okay, so these are the common, even hypoglycemia. Okay, so these are the some common causes that are metabolic and associated with the generalized chronic status epilepticus or generalized convulsive status epilepticus. Now, drug toxicity. Drug toxicity is certain drug toxicity or certain drugs which are enzyme inducers. Okay, that can also cause generalized convulsive status epilepticus. Then CNS infections or tumors. Okay, so even if you have CNS TB, tuberculosis, toxoplasmosis, neurocysticercosis, okay, any infection, either meningitis, tuberculous meningitis, very important cause for the status epilepticus. Okay, then refractory epilepsy. It's not getting better with the treatment. That is your mesial temporal epilepsy, one of the subtype. Then head trauma, which was the case in our patient. either HDH, which shows your tricentric bleed, or your SAH, okay, which shows in arachnoid hemorrhage, or your extradural hematoma, which shows this lentiform type of hemorrhage. Okay, so this can be. Now, what are the diagnostic indicators? So obviously, first will be generalized tonic-clonic movements that will give you overview that patient is having epilepsy or not. Then subtle signs after prolonged seizure like 30 to 50 minutes include mild clonic movements of the fingers, fine eye movements along with tachycardia, hypertension, pupillar dilation, and EEG will be confirmatory. Okay. So finally coming to the treatment. So always remember in treatment, we start with the benzodiazepines. Okay. So we start with the IV benzodiazepine, lorazepam 0.1 mg per kg. Very important. Or midazolam 0.2 mg per kg. Very important. Okay. So lorazepam or midazolam. That is the drug of the choice if they ask. Okay. Then we start with the after that, 5 to 30 minutes. So impending in between 5 to 30 minutes, you should start with the IV benzodiazepine. Then you should give anti-seizure medications. So in MCQ particularly, they will ask you what is the first line management, or what is the best approach or best management for the patient of status epilepticus. So they'll give you history. That patient was having status epilepticus since last 10 minutes, and then he was taken to the hospital. Now, what first medication you can give to this patient? So make sure you're right about the benzodiazepine. It sounds easy over here, but in exam you make this mistake. Okay. Then we talk about the anti-seizure. Your phenytoin is there. Then valproate is there. So phenytoin 20 mg per kg, valproate 20 to 30 mg per kg, levetristan 20 to 30 per kg. Then if it is generalized convulsive status epilepticus, or if it is a focal. So if it is focal, then give the further IV or PO anti-seizure drug. You can give valproate, levetristan. You can continue that. And similarly, if patient is still having, okay, and patient is having generalized convulsive, even after the 30 to 48 minutes, then you can again give midazolam. You can also give propofol. And still, if it is refractory, then you can give phenobarbital. Okay, so phenobarbital 5 mg per kg can be given. And eventually, other medications like lidocaine, verapamil, magnesium, ketogenic diet, immunomodulation, other anesthetics like isoflurane, desflurane, ketamine, even if patient is not improving, okay, refractory condition, and like surgery, etc., can also be done. Okay, so this is about in a nutshell, the approach to the status epilepticus. Now, what are the other conditions also with epilepsy? So, which psychiatric disorder is most commonly associated with the epilepsy, occur in approximately 20% of the patients? Yes, you guys. Yes, come on. Smart. You guys are so smart. Okay, but I am afraid that nobody is correct. Okay, the answer is depression. 20% of the patient can have depression after epilepsy. Okay, not post-ictal delirium, not anxiety, not psychosis. Okay, so that is the factual question. Okay, so that we have already discussed. Anesthetics, vagal nerve stimulation, ketogenic diet, immunomodulation, and electroconvulsive therapy can be given for the refractory status epilepticus. Okay, and this was the topic which we will discuss now. Okay, so depression is very important, and for that we give antidepressant, we give psychotherapy for these patients. Cognitive behavioral therapy is recommended. Okay, CBT is recommended. Now coming to the other types of the subtypes of the antiepileptics. So which anti-seizure is the most strongly associated with the increased risk of adverse fetal outcomes? Valproate or phenytoin? Which one? Valproate. Okay, valproate. So valproate should not be given. Then what is the recommended intervention for pregnant women on enzyme-inducing anti-seizure medication? So suppose you're taking phenytoin, or you're taking primidone, or you're taking rufinamide, etc. So these are all enzyme inducers. Okay, even carbamazepine can also be there. Okay. So what do we do in these conditions? If it is enzyme inducer, do we increase the folate supplement Do we increase the oral vitamin K supplements? Do we increase the anti-seizure, stop the anti-seizure medication, or replace the anti-seizure medication with herbal supplements? It is very logical questions, and you guys are failed to apply the logic. Ah, Rubina is correct. Okay, B she has answered. C, we are talking about the neonatal hemorrhage. Prevent neonatal hemorrhage. You guys know in all the hemorrhage, in your ICU, in your emergencies, etc., you have managed hemorrhage so many times. Why would we give folate in this condition, right? So we'll give vitamin K. So administer oral vitamin K during the last 2 weeks of pregnancy is the answer. You got it? So that's how you manage the conditions like this. I hope you got. So my point or my idea over here is to help you to rule out the options. And that's what we call learning over here. Okay. So coming to the subtypes of epilepsy, what is catamenial epilepsy? That is associated with the menstrual cycle. Okay, due to hormonal and pharmacokinetic changes. Now, the epilepsy that is associated with the pregnancy. Here, seizure changes can be 50%, increases in 30%, and decrease in 20%. Okay. Risks can be there with the anti-epileptic medication. Mostly we manage with the monotherapy. We should give folate, and to reduce neonatal hemorrhage, we should give the vitamin K also. Okay. So folate is for the neural tube defects prevention or teratogenic defects prevention. Contraception. So enzyme inducing drugs reduce oral contraceptive efficacy. So make sure you get either IUDs. Coming to the breastfeeding. So drugs excreted sometimes in the breastfeeding. So 300% for the levetiracetam and 5% for the valproate. Okay. So that's why you cannot give levetiracetam, the breastfeeding mothers. Okay. So that's it for the epilepsy. Now coming to the stroke. All right. Any doubt with this? Right. That's it. Now coming to the stroke. What is the primary cause for the ischemic stroke? Yes, it's very easy. You guys know this ischemic. Obviously, it will be embolism or thrombosis. Easy question. Easy question. So we know the strokes can be of two types, either hemorrhagic or ischemic. So if it is ischemic, it can be either thrombotic, embolic. Okay. So it is one of the commonest and second leading cause of the death globally. And US में तो prevalence है, India में भी prevalence बहुत ज़्यादा है अभी तो young population में भी बहुत दिख रहा है stroke. Okay, so what is the definition? There is an abrupt onset of neurological deficit caused by focal vascular event. Okay, so this is a focal vascular event, just a single vessel is involved, and either due to ischemia, that is blockage, or hemorrhage. Okay, so that is the definition. Now, this is how the division of the stroke causes have been done. So, ischemic is almost 85%. Okay, see that number. Hemorrhage is 15%. And in that hemorrhage also, SAH, ICH, intracranial hemorrhage is common. Hypertensive IC bleed is common, 7%. And SAH is 4%. Okay. Whereas in case of ischemic causes or thrombotic causes, if you can see, thrombotic are the commonest. Atrial fibrillation is almost 17% of the cause. Okay, so atrial fibrillation basically causes the embolic stroke. Thrombotic are because of the atherosclerosis. Thrombotic are because of the atherosclerosis. So atherosclerosis is the commonest cause. And when we talk about the embolic, 17% is by the atrial fibrillation. Okay, that is about the causes. So most common cause of the ischemic stroke, again, that is thrombosis. So here we can see ischemic stroke caused by the reduction in the cerebral blood flow. Hemorrhagic is by the bleeding into the brain. Common causes of ischemic stroke is the commonest. And symptoms, we know that depending on what area it is involving, you can have different symptoms in the stroke. Okay. Yes. Coming to the transient ischemic attack. So for how many period, for how much period TI will be there? So less than 24 hours. Patient completely gets better within 24 hours. And there is no evidence of the brain infarction on imaging. So this is the new point that is added. So how will you get in question in your exam? So you'll get the question in an exam. All of the following is true about the TI except number one. It is the transient occurrence of the neurological signs, and symptoms usually last less than 24 hours. MRI is used. The option number B will be MRI are usually normal in this patient. Option number 3 can be for TIA. We use ABCD2 score for secondary prevention of the stroke. Okay. And third option will be MRI is must to rule out the MRI is must. Obviously, MRI is a must. That will not be option. But yeah, TIA does not signify the risk of the upcoming stroke in the future. So answer would be D, right? Because TIA imaging is important, 24 hours duration is important. It also increases the risk of the stroke, and that's why we are giving ABCD score. Diagnosis, obviously, MRI will be required, and risk of the stroke is increased short-term risk of the stroke. That's why we start with the anticoagulants and antiplatelets. Okay. Now starting with the stroke mimics. So which of the following condition can mimic a stroke due to sudden neurological symptom, but it is not related to cerebrovascular events? Yes, you guys. Which of the following is a stroke mimic? Yeah, all of the above. Everything is stroke mimic. Okay. So can be either seizure, brain tumor, migraine, metabolic encephalopathy. Everything can be your stroke mimic. Then pathophysiology of the ischemic stroke. What is the main concept behind the ischemic stroke treatment? So the answer will be, you guys know this, reversing ischemia quickly. Because whenever certain part of the brain, so suppose this is one part of the brain and this is the other part of the brain. Okay. So yeah, like this. So if this part is dead, obviously around that we have certain part of the tissue which is under the threat. And for that, our role will be to reverse the ischemia quickly. And that happens because of the collateral formation. Okay. So that is called as ischemic penumbra prevention. I hope you understood. Okay. So that is the main concept behind the treatment. Now let's see. So when we talk about the stroke, this is very important point that tissue death usually occurs when there is no blood flow for 4 to 10 minutes. Okay. Now ischemic penumbra, that's what concept I just explained. Okay. The part around the dead tissue is called a ischemic penumbra. Necrosis, apoptosis can occur during the death of the tissue, and effects of fever, hyperglycemia, adverse effects in healing of the ischemia. Okay, so make sure patient does not having fever. Sugars are also normal. Okay, so why I've added this point? Because this can be asked which of the following is true about the stroke. Okay. Coming to the initial evaluation, obviously you do CT scan. Depending on the protocol, we do the CT scan or MRI. We rule out the hemorrhage, and then if patient is in the window period, that is less than 4.5 hours. Okay, 3 to 4.5 hours, we do IV thrombolysis. If patient is within 6 hours, if patient is coming and the large vessels are involved. So what are the large vessels? Large vessels like MCA, ICA. Okay, if this is involved, then we go for the thrombectomy. Okay. Then lastly, medical support, obviously. So that is about the treatment of the stroke. We'll discuss thrombolysis, don't worry. Then we have certain neuroprotection and the stroke centers are also there. So how do we form the stroke unit? Let's see that. So what therapy is commonly used in patients with cardiac arrest and is being studied for the potential benefit of the ischemic stroke? So that is hypothermia. Okay. So hypothermia helps in the cardiac strokes or any strokes, basically cardiac arrest, which can lead to the stroke also. So neuroprotection with the help of hypothermia can be done. And we also form the stroke units so that there is a quick response to the patient coming with the strokes. Okay. So I hope you are understanding. Now coming to the anti-thrombotic treatment for the stroke. So obviously anti-thrombotic therapy will be required. Okay. So which antiplatelet agent is commonly used? You guys know aspirin is the most common, right? So aspirin is the antiplatelet drug can be used. You can combine aspirin with the clopidogrel, and anticoagulation is also recommended with the heparin or warfarin. Okay. So it is recommended for the embolic stroke. Make sure you know this. Not for the, okay, so atherosclerotic lesions, it is not recommended, but it is recommended for the embolic stroke. Embolic stroke, you know what are the causes? That is mostly cardiac arrhythmias. Okay, so cardioembolic stroke, like atrial fibrillation. Okay, I hope you understood. Now, how do we do endovascular therapy and thrombectomy? So, as I said, it is must be done in the large occluded intracranial vessels, like the middle cerebral artery, and it is most effective within the 6 hours of the stroke onset. It's a very important point. Okay, and what is the primary goal for this? So, obviously, that is to restore the blood flow to the large occluded vessels. That is the goal. Okay, so imaging, we will do CT scan, we will do the MRI perfusion scan, we will do the CT angiography to identify the vessels which are involved, and after that we come on to the conclusion. Okay, so outcome improvement will be obviously there if you do the surgery as soon as possible within 24 hours. Okay, that is thrombectomy. Now recent guidelines are saying that within 24 hours you can do that. Okay, coming to the introduction to the subarachnoid hemorrhage now. So this is the hemorrhagic stroke. Okay, we've discussed this. Now let's discuss the hemorrhagic stroke. So in hemorrhagic stroke, as I said, we have SAH, we have SDH, and we have EDH. Okay, these are the common subtypes, or ICH is also there, intracranial hemorrhage. So talking about the SAH now. So HS is what is the most common cause of the subarachnoid hemorrhage, excluding head trauma? Number one is obviously head trauma. Number two is, yes, you guys know this. 1, 2, 3, 4. Quickly. Rupture of the, yes, that is the correct answer. Okay, rupture of the saccular aneurysm or Bailey aneurysm that is formed. All right. So that is usually formed between the communicating artery. Okay, intercommunicating artery at the your circle of Willis. Okay, so subarachnoid hemorrhage is the bleeding into the subarachnoid space, and most common cause is the rupture of the saccular or Bailey aneurysm. And what are the other causes? So other causes can be AV malformation, dural AV fissulas, and with extension to the primary intracerebral hemorrhage. Okay, idiopathic SH can be, you don't know exactly what are the causes behind that. I mean, angiography is often helpful. Okay, yes. So what is pathophysiology? That is saccular or vein aneurysm. What exactly is this? Where do we see it commonly? You guys know this? Why do saccular aneurysm most commonly occur in the brain? Where it occurs? Yes, don't see over here. So this is very important at the bifurcation of the large to medium sized intracranial arteries. Okay, so you know the circle of Willis is correct answer, but this is the more correct. It occurs at the branching of the arteries. Okay, so saccular aneurysm mostly is outpouching of the cerebral artery, commonly known as the Berry aneurysm, because it is a berry-like in shape, and it is most commonly associated with the bifurcation of the large to medium sized cranial arteries, and particularly in the circle of Willis. Okay, risk factors for the rupture, that is aneurysm size more than 7 mm. Specific location like basilar bifurcation, posterior communicating artery, and the patient age. So this question will be asked that which of the following is correct about the Berry aneurysm. So it is commonly seen in the bifurcation of the large and the medium arteries. Second, it is usually associated with the rupture risk if the size is more than 7 mm. Then it is usually associated with the increased rupture risk if it is seen in the at the basilar bifurcation and the posterior communicating artery. And fourthly, it is not dependent on the patient age. So yes, it is dependent on the patient age. So that's how you read everything while you're reading. Okay. Finally, structural changes, obviously, aneurysm develop neck and dome, and arterial walls thin at the dome, and that can lead to the rupture of the subarachnoid hemorrhage into the subarachnoid space. Okay. So what is the hallmark symptom of the aneurysmal rupture causing subarachnoid hemorrhage? Okay, so obviously that is the sudden onset severe headache. It's the commonest feature, and that will be the worst headache of the patient's life. Okay, so the hallmark of the aneurysm is sudden onset of the severe headache. That is called as worst headache of the severe life because of the rupture of the aneurysm. The sudden rise in the intracranial pressure occurs because of this, and transient loss of consciousness can also occur. Okay, can also associate with neck stiffness, etc., vomiting, photophobia. And prodromal signs can be prior to rupture. Okay, sometimes you can see the prodromal signs also prior to rupture. Now, coming to the DNDs in the SH. This is also one MCQ. That is, what is DND in SH? Okay, which of the following is the major cause of DND after the subarachnoid hemorrhage? That is delayed neurological deficient. Okay, so what is the main cause for that? Infection, hyponatremia, cerebral vasospasm leading to delayed cerebral ischemia, or seizure activity. So this is the cerebral vasospasm leading to delayed cerebral ischemia, and for that we use one drug that is called as nimodipine. You guys know this nimodipine? It is calcium channel blocker, and this avoids the cerebral vasospasm, preventing the delayed cerebral ischemia and the DNDs. I hope you guys know this one. Okay. So delayed neurological deficits after SH are prevented by preventing the cerebral vasospasm. So whenever there is a bleed in the brain, four major causes that causes DNDs are rupture of the aneurysm, hydrocephalus, delayed cerebral ischemia due to vasospasm, and the hyponatremia. Okay, so delayed cerebral ischemia we know can occur because of the vasospasm of the cerebral arteries, can lead to the delayed cerebral ischemia, typically occurs 4 to 14 days and peaking around the 7 days. Okay, so very important these points. And hydrocephalus because of the accumulation of the CSF. Hyponatremia is again because of the salt vesting. Okay, so for evaluation, obviously we get the MRI scan done. Usually we get the picture with the CT scan itself. And then if needed, we can do the MRI. We can do lumbar puncture. We get the xanthochromia. You guys know this, right? It detects the xanthochromia. That means yellow discoloration. Okay, yellow cells can be seen. Angiography, ECG changes can also be seen with the T-wave inversions. Okay, T-wave inversions can be seen in these patients. So how do we treat this patient? So for treatment, we already discussed this. Delayed cerebral ischemia after subarachnoid hemorrhage can be prevented by nimodipine. Okay, so medical management with the help of nimodipine, we prevent the vasospasm. We already discussed that part. Aneurysmal repair can be done, and vasospasm treatment can be done. And usually, if there is a bleed, there is an increase in the intracranial tension, then we give nimodipine. Then we give mannitol. Okay, so mannitol is to be given. Then once the intracranial tension is getting settled a bit, you can reduce the mannitol. Okay, so that's it about the stroke. All right. Then we have different types of headache. Probably we should take it in the next class. Okay. Tomorrow we will take that. All right, guys. I hope you understood whatever things we discussed today. I want you to revise these two important topics, seizures and stroke, and then we will catch up tomorrow. Okay. Is there any doubt? Is there any doubt? I think we were able to cover important topics. Huh? Great, great. Okay. I've shared the PPT in the group itself, and just go through that PPT, just revise those stuff, and make sure you solve the questions also side by side from your platforms, whatever you're using, and you get your concepts clear. Okay. Okay, then we'll meet at same time, mostly 6 p.m. And I'll just inform at 5:30. I'll inform you. Okay. Okay. Yes. Okay, then. Bye bye. I have shared the stream link already in the group. You can. I've already shared the stream link in the group. Okay. Topic for tomorrow. We will cover migraine, types of headaches. We will cover uh, Parkinson's. We will cover Alzheimer's, that's neurodegenerative disorders. We will cover dementia also tomorrow. Okay. And if possible, we will cover the movement disorders. Okay. So read neurodegenerative disorders, Parkinson's, Alzheimer's, and the headaches for tomorrow. Okay. Yeah, I've already shared the notes. You can just go through that. Embolic stroke to start heparin, patient should have atrial fibrillation. See, embolic are mostly because of the atrial fibrillation. So we usually start for the embolic, we start with the anticoagulants. Not necessarily heparin, you can start oral as well, depending on the patient's or like patient's condition. Okay, it's basically individualized approach. If the patient is having high risk for the DVTs, etc., and all those things are there, or you're suspecting that there is a artery to artery or vein to artery emboli, then you can start with the heparin or any other anticoagulants in these cases. Okay, all right. Thank you so much, guys. Bye bye.